You finally get your PCOS diagnosis after years of having irregular cycles, acne, and weight management issues. And you're relieved. Finally, you have an answer. And then your doctor says, come back when you want to get pregnant. Or they say, here's a pill. Start it and it'll regulate your cycles. Without much of an explanation. And then you think, wait, what? That's it? I'm naturopathic Dr. Ann Hussain, and this is Phase to Phase, the Hormone Health Show. And today's episode is all about PCOS. Polycystic Ovary Syndrome is a condition I am very, very, very familiar with because I have PCOS. Almost half of my patients that I see in my Ontario clinical practice is PCOS, anywhere from fertility patients, perimenopausal patients, newly diagnosed patients, and everything in between. PCOS is very common. 1 in 10 menstruators is the average that we have currently, and it depends where you are in the world. That number shifts just a little bit. But the conversation we have about PCOS is still quite narrow. We primarily look at it as a fertility or reproductive issue only, one that only pertains to your menstrual cycles. But the thing is, PCOS is a multi-system condition, and it's a lifelong condition. Yes, we can treat it. Yes, we can manage it, but it affects all parts of you. And it affects almost every system in your body. So in this episode, we are covering what PCOS is and what it can look like, because it can look different for different people, what the root cause of PCOS is, and this is a question I get in practice all the time. And then we're going to end off by talking about how you can start building your health plan, one that's rooted in science, one that's rooted in your goals, your reality, because there is no one-size-fits-all solution. Let's get into it. So PCOS is a lifelong condition. I'm going to repeat that a few times because I want you to really understand that deeply. Yes, there will be times where you don't have a lot of the symptoms or any of the symptoms, but the background stuff that causes PCOS, the background physiology that's part and parcel of PCOS, that's still there. It doesn't get cured. We treat it and we manage it. And even though the name is PCOS, Polycystic Ovary Syndrome, you do not actually have to have polycystic ovaries in order to have PCOS. And I know this is super confusing. Even if we take a look at someone who has multiple cysts, and technically that would be polycystic ovaries, that's not what polycystic ovaries means. Polycystic ovary and PCOS means something very specific. You have large ovaries, like your volume of your ovary is very large if we look at it on ultrasound, or you have 20 or more follicles in one or more ovary. So it's what makes PCOS diagnosis a little bit confusing. Also, because when you're young and when you've just started your menstrual cycles, having polycystic ovaries is actually a common finding as you're starting to learn and as your body is starting to learn to actually have a menstrual cycle, and until you reach reproductive maturity, which is around 8 years after you start your menstrual cycle. All in all, to say, you don't have to have polycystic ovaries to have PCOS. I'm going to quickly touch on the diagnostic criteria because I don't really want to focus on that. I want to talk more about what you may be experiencing. So the diagnostic criteria, you have to meet 2 out of 3. One is irregular cycles or anovulatory cycles. So you're having longer cycles, or you're having cycles where you're not ovulating. And we know this because we've tested you, for example. Although we can really just tell if you are having longer cycles, then you likely are either not ovulating or you're ovulating irregularly. And ovulation is what dictates the length of a menstrual cycle. If you have regular ovulation, you're going to have regular periods, regular menstrual cycles. If you have irregular ovulation or missing ovulation, then your cycles are likely going to be irregular, and that can show up as long cycles, that can show up as MIA cycles, that can show up as irregular bleeds, like sometimes you only spot, sometimes you have like really prolonged and heavy bleeds. All of those could be true. The second criterion that needs to be met is hyperandrogenism. So androgens are these hormones that we associated with biological males, so testosterone and DHEA. And this can show up as cystic nodular acne, or acne that doesn't really respond to your normal treatments. It can look like hirsutism or body hair growth, especially upper lip, jaw and chin, back, inner thighs, lower pubic area, around the chest and nipples. And we're talking about thick, coarse hair, not like peach fuzz or like light, thin, vellus hair is what we call it. And hormonal hair loss on the head. So typically we're seeing that at the front and the part and the top of the head. So hyperandrogenism, you can see that clinically, as in you have signs and symptoms, or we're testing your blood and we are seeing elevated levels of testosterone and or DHEA or androstenedione. Those are the three that we're typically testing. But if you have the signs and symptoms, we don't need to test you. We know based on your signs and symptoms. The third criterion, we only move on to it if you don't have the first two, and that's taking a look at ultrasound and seeing if you have polycystic ovaries or if you have your AMH tested. So AMH is anti-Müllerian hormone. It's an ovarian reserve test. But because that AMH is made by immature follicles, and that's what the polycystic and polycystic ovarian syndrome is, it's immature follicles in your ovary, those are making AMH, so those levels can be elevated. It's not a true representation of how many eggs that you actually have, like in fertility settings we test it. In fact, this is because you have PCOS, and that's why we're seeing high AMH. So that's the diagnostic criteria. And then we also have to rule out things that look like PCOS. So if you have a thyroid disorder, if you have high prolactin levels, so prolactin is a hormone associated with breast milk production, or if you have some other adrenal pathology, those are other things that we want to make sure we're ruling out if we're giving you a diagnosis of PCOS. So that's the diagnosis. But what that means for you as someone with PCOS is that you may have irregular cycles whereby sometimes you get a period that is, very regular, like maybe you get it every 30 days or 35 days, and then it starts getting 45 days, 60 days, 3 months, or 6 months. And what I want to say here is that if you are someone who goes without a period for a long period of time, like 3 or more months, we should be reaching out to your medical team, so your medical doctor, naturopathic doctor, nurse practitioner, to shed that lining that is building up. Because that buildup of the lining can be endometrial hyperplasia. So endometrial hyperplasia, all that means is that the inside of your uterine lining, or that uterine lining that typically grows in a menstrual cycle, it is growing abnormally and uncontrollably, and that puts you at risk for endometrial or uterine cancer down the line. The chances of cancer are low, but we still want to shed that lining in a timely fashion, and we typically do that by giving you a prescription of progesterone or progestin. You take it for 7 to 10 days. After you're done that course, you typically will have a bleed, kind of like when you go on the birth control pill. And one of the benefits of going on the birth control pill for PCOS and why it's oftentimes prescribed is to prevent this from happening. The other symptoms that you might have as someone with PCOS, we've already talked about, are the acne, hair growth on the body and face, and hair loss where you don't want it. And that's sometimes not associated with an increased testosterone level in your bloodstream. Not because you're not responding to testosterone or you're not responding to the DHEA, those androgenic hormones. It's simply because your skin and your hair is responding to it. Whether you have elevated levels in your bloodstream, it doesn't really matter. We still treat you and we still support you with your acne and your hormonal hair loss and your hormonal hair growth. So those are some of the other symptoms that a PCOS can show up with. Hidradenitis suppurativa, which is a skin condition which can lead to large boils, especially in areas where there's skin-to-skin friction. That's another manifestation that can happen. Acanthosis nigricans, which is darkening of the skin folds. This is oftentimes found in people with blood sugar dysregulation. That can be a presentation for you. Fertility issues are common in PCOS. PCOS is not an infertility diagnosis, but because there's so much hormonal dysfunction, there can be infertility or subfertility for which you may or may not need support. And this is multifactorial. Some of it could be because you are not ovulating regularly and you don't know when to time intercourse. Some of it could be that you're not ovulating at all, and we definitely need an egg in order to get pregnant. Some of it could be more insulin resistance and testosterone related, so egg quality changes can be happening, and or placental growth in early pregnancy can be affected. As in the vasculature and the blood vessels that are forming in a placenta aren't as robust because of the hormonal and metabolic dysfunction that's happening in the background, which means that you're at higher risk for early pregnancy loss, small for gestational age babies. You're also at higher risk for gestational diabetes and gestational hypertension. So high blood pressure during pregnancy. So there's a lot of fertility barriers, but also having a healthy pregnancy kind of barriers or increased risk of pregnancy complications that can happen, which we can mitigate a lot of those if we work on your health prior to conception. The other thing that can be present in PCOS is insulin resistance and metabolic dysfunction. So essentially the beginnings of blood sugar dysregulation. There could be a lot more fat around the liver. There is a higher risk for heart disease and heart disease risk factors like high cholesterol, high blood pressure, even diabetes. And then weight management issues, whereby we're putting a lot more fat around our abdominal organs. And that's why you'll also see that weight loss of 5 to 10% is recommended as a treatment for PCOS, because when we decrease some of that abdominal fat, we actually do see improvement in the overall hormonal picture. And that's because PCOS is not just a reproductive issue, it's also a metabolic issue. Nervous system issues as well. So there's a higher rate of anxiety, higher rate of depression, higher rate of body dysmorphia and body image distress. There can be disordered eating and, like I said, difficulty managing weight. People find that it's easy to put on weight, especially around the midsection, and very difficult to lose weight. And here's where I get a lot of questions about what caused PCOS. What is the root cause of PCOS? What did I do to cause PCOS from my patients and also from community members? PCOS is not your fault. PCOS is also not rooted in one single factor or one single cause. It is a complex, multifactorial, multi-system condition. Just like any other chronic condition, if we take heart disease, for example, on its own, it also wasn't caused by one thing. It wasn't just genetics. It was genetics plus family upbringing, plus exercise over time, plus stress, plus. And PCOS is no different. There is a big genetic component in there. And then there's also an epigenetic component. So how were those genes expressed when you were in the womb? How were those genes expressed as you were getting older? What things were you exposed to? What kind of food did you get when you were growing up? The consistency of food. What is your family background? Did they descend from a different part of the world where there's certain genes that can be turned on and off, or certain genes that have slight mutations in them that cause metabolic dysfunction or appetite dysregulation or hormonal problems? There's over 200 genes that we've identified that can be involved in PCOS pathology. And depending on what your family ancestry is like, different parts of the world have different genes that can be influenced or affected. And you might have inherited a certain set of genes, and then when you were growing up, those were expressed in a certain way. So there's a strong genetic component there. And then over time, there's hormones and metabolic health, your environment and your development, your exposures, but also stress and environmental pollutants perspective, like all of the bits. And then your medical history and your lifestyle. How has that looked? Where are we currently at? What phase of life are you currently in? Have you already had a pregnancy where you had gestational diabetes, which puts you at higher risk for developing diabetes? There's so many different factors. And that's what I really want you to remember, that it's not your fault. There's lots of things that we can do, some of which we have control over and some of which we don't. We can't go back and change your genetics. We can't go back and change your family history. We can't go back and change your upbringing, but we can start to influence a lot of these metabolic and hormonal issues over time. And some of those things are really going to look like your foundations and your lifestyle. So these are the things that you do have control over. You might have only a little bit of control over right now, depending on who you are, what access to resources you have currently, where you live, and that sort of thing. But we can all start to make some changes. Let's start with nutrition first. So nutrition isn't likely going to fix all the things about your PCOS, but it is a really big foundation to set yourself up for the future, whether you have fertility goals or not, and to improve your health now. And the sooner you start, the longer the runway you have. And that's where we really need to have more conversations about how we bring in different components of your health and life together to have a synergistic effect over time, instead of just relying on one thing, because one thing isn't likely going to quote unquote fix your PCOS symptoms. They're not going to magically change everything, but small changes in all areas like your nutrition, exercise, sleep, stress, connection, education, even learning more about it, and supplementation and medication, all of those combined can do a really beautiful job of having your acne improve, having your cycles regulate, helping you decrease some of the pregnancy risks that are associated with PCOS, also lessening the impact of perimenopausal hormone changes on your metabolic health, like your cholesterol and blood pressure and all of the things that start to change at that point in time naturally. So there's lots we can do. So let's go back to nutrition for a sec. You do not need to cut out whole food groups. Let's start there, because there is so much noise online when it comes to nutrition and PCOS and nutrition in general. And I see so much orthorexia promoted online, and orthorexia is really like this obsession with healthy eating, loosely speaking. We want a diverse diet, a diet that has lots and lots of plant foods. I know we focus a lot on protein, and protein is very important, but more important than protein arguably is fiber. Fiber in North America especially, we have such a large portion of our population that does not hit its fiber targets for the day. For adults, for adult women specifically, it's around 25 grams of fiber per day. And fiber only comes from plants. It doesn't matter what kind of plant you eat, whether it's grains, nuts, seeds, fruits, veggies, it's legumes, lentils, whatever. That's where your fiber is going to come from. And fiber is a large group of compounds. It's not, like a vitamin C. It's like me saying, go take a vitamin. You're going to ask, what kind of vitamin should I take? Same thing with fiber. There's no one singular fiber. There's lots of different kinds of fiber. And the more diverse your diet is, the more the different kinds of fibers that you'll be exposed to. Not just that, the benefit of eating more fiber is also the things that fiber comes with. If you're eating more plants, you're also getting more antioxidants. You're also getting more magnesium. You're also getting more vitamins and minerals. And you're getting sources of lean protein oftentimes. So we want to emphasize those plants a lot, because IBS is also quite common in PCOS. If you are someone who tends toward IBS or has like digestive problems, then the way you want to increase your fiber over time is very slowly. I mean like super slowly over months and months, because your body will get used to it and build a tolerance to it over time. There still might be some foods that aggravate you more. And sometimes it's not the food itself, but the quantity of food. So you might be okay with a quarter cup of rice, but if you have half a cup of rice, like that's just too much. So those are the kinds of things that you can pay attention to. You do not need to cut out carbs. Carbs are fuel. Yes, we want to make sure that we're having more whole grain carbs, and we want to make sure that when we are having carbs, it's cushioned by our fats and proteins and fibers, right? We want to create balance in our meals and snacks, and that's what's going to help with blood sugar regulation, because we do want to make sure we're regulating that blood sugar. We also want to have lots of omega-3s, and dietary omega-3s are just fine. And if you are someone who eats fish, that could come from fish. If you are someone who's plant-based or doesn't eat fish, then your nuts and seeds are a great source of dietary omega-3s. But the point here is there's no one-size-fits-all nutrition solution. There's lots of studies we've actually done on PCOS and nutrition, and the diets that come out ahead for supporting PCOS are heart-healthy diets, like the Mediterranean diet, diets that are like whole food plant-based, that are plant-forward essentially, ones that have low amounts of red meat or avoiding red meat, because red meat independently can increase the risk of heart disease, cholesterol, high blood pressure. They're low in saturated fat. So saturated fat is solid at room temperature, and it primarily will come from your butter and red meats. You want diets that include olive oil or other plant oils, having nuts and seeds and lentils and legumes on a regular basis. We want berries in there. We want less amounts of sugar-sweetened drinks. So those are the kinds of diets that are helpful for PCOS and for your overall health. And that's the steps we want to take. I always like to start with adding nutritious things in, like fiber, or like an apple will give you 4 to 5 grams of fiber per day, versus removing whole food groups out. If you're sensitive to something or allergic to something, by all means, please take it out. I will say another thing, which is that for some people with like chronic cystic acne, sometimes removing dairy can be helpful, but that isn't universally true. You likely have to try that out to see if that's true for you or not. Now, next up is exercise. As we all know, there is no replacement for exercise in our life for all the things. Exercise helps with mental health. It helps with mood. It helps with sleep quality. It helps with insulin resistance. It helps with body composition. And there's lots of myths out there about what kind of exercise is best in PCOS. And I'm going to be the one to tell you, hopefully other people are also telling you, that there is no one exercise that reigns supreme when it comes to PCOS. The same guidelines that we have for heart health apply, which is we do cardio. Cardio has very real benefits to your cardiovascular system, to your heart and blood vessels and your lung capacity. We also do strength training because it helps you build muscle. It improves your metabolic rate. It protects your metabolic rate. It also helps with longevity in your bones, and it helps with blood sugar regulation. And we try to decrease sedentary time, so your sitting time, your inactive time, and we add in other non-exercise kinds of movement. So you're walking, you're getting around and doing things, you're stretching, and all of the bits. So an ideal PCOS exercise plan is the same as a heart-healthy exercise regimen, is the same as a brain-healthy exercise regimen. It includes all of the things. And it has to be rooted in something that is practical for you and doable for you. So start with anything. And I think where people struggle the most is the all or nothing thinking that they fall into, that a workout needs to look like 30 minutes or it isn't exercise at all. But that's not true. Literally, even if you move your body for 2 minutes in a week, it's better than doing 0 minutes in a week. And the same thing with vegetables and fruit, going back to nutrition. Literally 1 apple per week more than the week before is still better than no apple additionally at all. And that's the kind of mindset change, the flexibility that we need to build over time that a lot of us struggle with. I see patients every single day who say the same thing. And then when we do this reframe, they're like, oh yeah, that makes sense. But it takes time to actually have that be part of your life. I'll encourage you to move in whatever way is doable for you right now. It likely needs to go into your schedule. You likely need to plan it a little bit. Maybe you need a personal trainer to help you stick with those goals. Whatever that looks like, please move your body. Over-exercising while under-eating, that's the problem. That's where we get a lot of this cortisol spiking. Exercise in the long run helps with your cortisol regulation. You making a little bit of cortisol as a response to exercise is a normal physiological response. What we don't want is for you to over-exercise and only do high-intensity exercise multiple times per day, multiple times per week, while you're under fueling or while you're super stressed or while you're not taking care of yourself and you're depleting yourself. That's something we don't want. But for most of us, high-intensity exercise is actually a great thing to add for your PCOS, for your overall health. The other things that we wanted to work on foundationally for your PCOS is your sleep. Sleep apnea is very common in PCOS. So if you are someone who sleeps adequately, but maybe have gained a little bit of weight, or you snore, or you clench your jaw, or you wake up in the middle of the night out of breath, or you're frequently urinating in the middle of the night, or you're just getting enough sleep, but waking up feeling like, oh my gosh, I feel like I haven't slept at all. Those could be signs that we're looking at some sleep apnea. A sleep study can be helpful to illuminate that. And sleep apnea is 3 times more common in PCOS than in the non-PCOS population if we're looking at the same age group. So sleep apnea is a big consideration, but you need to work on your sleep. Lack of sleep will affect your metabolism. It will affect your appetite specifically, and it makes you feel crummy. So even if you're trying to make lifestyle change, it's going to make everything worse. And sleep apnea can increase your blood pressure. So it can lead to hypertension or contribute to hypertension. So especially in those perimenopausal patients with PCOS who are at higher risk of having heart disease risk factors like high blood pressure, with sleep apnea, you can have an increased risk of that. Now, weight loss can be helpful, as I mentioned earlier. So 5 to 10% of weight loss can be helpful for pregnancy rates and fertility, for healthier pregnancy outcomes, for regulating your menstrual cycle, for improving things like fatty liver and insulin resistance, cholesterol. So weight loss can be helpful, and putting on more muscle can also be helpful. So ultimately, there's lots of ways that we can do that. And I encourage you to listen to the episode with Dr. Ashley White that we did on weight loss to sort of dive into that a little bit more. But it's not the only solution that's out there. And then stress management, learning more about PCOS, learning more about the nuances of your body, really tracking your menstrual cycle, tracking your signs and symptoms over time is always very important. And I can't emphasize that enough. There's supplementation that can be used. The most common ones would be inositols. Inositols can be helpful for blood sugar regulation, insulin resistance, for fertility, to decrease the risk of gestational diabetes, to improve ovulation rates, and even to help with some of those testosterogenic symptoms. There's medications that are like inositol or that have a similar impact as inositol, and that would be your blood sugar regulating medications like metformin. Other supplements like berberine and N-acetylcysteine or NAC can be helpful. As always, please talk to a knowledgeable healthcare provider and your medical team to see what is appropriate for you based on where you're at and what your goals are, because not everyone needs everything. And depending on how well you respond to some of the other things or what else is going on in your health, your plan should really be catered to you. Then for some of the other symptoms, like, for example, acne, for hair loss, for regulating your menstrual cycles, there's other things that we can use as well. So spironolactone is a medication that can be used for acne, hirsutism, and the hair loss. We could use Accutane or antibiotics, benzoyl peroxide, some of the acne treatments for the acne itself. I want to just briefly talk about the birth control pill for a second, because oftentimes it is prescribed for people with PCOS, and it is prescribed without much explanation. And I think it deserves an explanation because it can be a tool that some of you can really benefit from. Not that, you have to go that route, or maybe you were prescribed it in the past. I was prescribed it in the past and I didn't know why. I thought it was just a bandage solution. But in PCOS, oftentimes the pill is prescribed because it takes care of a few of the things that are happening and decreases some of the risks that are involved in PCOS. It decreases the risk of endometrial cancer. It decreases the risk of that uncontrolled uterine lining growth that can happen if you go months on end without a period. It also decreases circulating testosterone. The pill increases something called SHBG, or sex hormone binding globulin, that can bind to free testosterone in your system, and that can actually decrease your acne. It might also decrease some of your other testosterogenic symptoms. It also offers contraception for those of you who are looking for contraception, and if your cycles are irregular and you're constantly worrying about it, that's a fair consideration for you. And for a lot of you, especially when you're younger, it can also be subsidized. So inositol, for example, or if you don't have a drug plan and you're using medication, prices can add up, but the birth control pill is subsidized in Ontario, especially where we are, and most of Canada. So those are some of the considerations that we're having. You can always come off it. You still obviously may not tolerate it well. I didn't tolerate it well, which is why I came off it originally. I started getting migraines on it, and I also had a lot of mood changes. And I wanted to know what was going on because I didn't have a diagnosis at the time. So for me, it was prescribed in a way where I wasn't given a diagnosis, and I also felt really shitty on it. But you can make a very informed decision about using the pill, whether it's short-term or long-term, if that suits your life and your goals and your values. And then there's a lot of other things we can use. So we can use medications for weight loss, for example, and blood sugar regulation. For fertility, there's a lot of medications as well as treatments that we can use. And the last thing I'll leave you with is really tracking your menstrual cycles, tracking your signs and symptoms, and really educating yourself about PCOS. I'm going to leave you in the show notes a couple of links that you can take a look at. If you struggle with PCOS acne, if you are struggling with fertility, there's a blog post I'll leave in there. And then if you're sort of trying to understand if you have PCOS or what it can look like, there's going to be a blog post linked to that as well. But really, I really encourage you to gather a team of professionals, because this is a multifaceted, multi-system condition that affects your reproductive system, like your ovaries. It affects your nervous system and mental health. It affects your digestion, your metabolic health, your heart health. It affects all of it. And one health professional is likely not going to be able to help you with that, especially because this is a condition that's going to change. Hormones change naturally over time. Your body will change naturally over time. And with PCOS, some of those changes might be pronounced at different parts of your life. And that's okay. That's part and parcel of having PCOS. But gathering a team and adjusting your plan over time is really the way to go. And starting now, wherever you are, is the way to go. And the more you can track and have good notes about your health, the better you can communicate with your healthcare team. And that's what I want to leave you with. PCOS is long-term. I have PCOS. I support a lot of people with PCOS. There's some things that are within your control, and there are some things that are not. Regardless, I want you to feel well. I want you to feel empowered. And I want you to really choose the plan and choose items within your plan that fit you and your lifestyle as you move forward. If you know someone struggling with PCOS, make sure to share this episode with them. All the resources I mentioned in today's episode will be in the show notes. Make sure to follow and subscribe wherever you get your podcasts or at face2face.ca.